Hello and welcome to Women's Health. Women's Health is a collaboration between the Mayor's Commission on Women and 10 Health. My name is Kathy Ermacher and I currently serve as the chair of the Mayor's Commission on Women. I'm joined today by fellow Commissioner Pat Shepard. Welcome, Pat.
Thank you.
And our topic today is hormone replacement therapy. Our guest is Dr. Deanna Hutchins, and we want to welcome you. Thank you for coming.
Thank you.
Okay. And as I said, our topic today is hormone replacement therapy. There are so many women today who have been asking questions about this, and it's such an appropriate topic that we decided to dedicate one of our programs to hormone replacement therapy. So, Dr. Hutchins, can you give us a little brief sort of overview? What is hormone replacement therapy? What are we talking about when we say that?
Well, hormone replacement therapy is where we replace the hormones that the body is naturally losing at menopause. And if you think about it or go back to the basics, women are born with a finite number of eggs, in the millions actually at birth, and those are subsequently depleted through the years, so that by the time we approach age 51 or 52 or somewhere in there, we are deficient in not only eggs, but our hormones start to fall. Those hormones being produced from the ovary, specifically the testosterone, estrogen, and progesterone, become very low at that stage, and so women start having subsequent symptoms of menopause, hot flashes, night sweats. Most women have some of those anyway, and so some women get to the point where they would like to go ahead and take hormone replacement therapy.
Okay. Do we have any statistics? I mean, how many women are we talking about?
Well, back in 2001, 42% of women were actually on hormone replacement therapy in the ages between like 50 and 74. By July of 2003, that had dwindled to 28%, which was a significant decrease,
well, yeah.
Especially for the drug companies it was. And there was a reason for that. Before 2001, doctors had always felt that it was a good thing to be on hormone replacement therapy because we felt there was some evidence that might be protective against heart disease. Well, a study was started in the late 1990s, basically, to study that process, and they subsequently found that and then this came about in July 2002, that it no longer protected against heart disease, but it actually increased the risk of breast cancer. Mm-hmm. And so at that point, they actually stopped the study because it was a fairly significant risk, especially for women that were on both hormones, progesterone and estrogen. It was the study was actually pertained to the product called Prempro.
Yes,
as well as Premarin.
Mm-hmm.
And so at that point, most women started going off of their hormone replacement therapy, so from 42% down to 28% by July that next year. And that was a big step down. Subsequently, we found that study had women participate, at least 70% were actually over the age of 65. And over the age of 65 is where a lot of heart disease develops anyway. So it was a little skewed by that.
Right.
And they also found that women that were taking estrogen alone did not seem to have an increased risk of breast cancer at that point. So those are the numbers associated with that particular time frame. Mm-hmm. And I would say that there certainly are not those numbers that are taking it nowadays that were taking it prior to 2001, but it's certainly come up from probably the 28%.
So it has increased from that time on. Mm-hmm. As more and more information comes about, then more and more people make individual choices.
Exactly.
Right.
Yeah.
Okay.
And women were going off of their hormones just cold turkey at that point, and they were having so many hot flashes and feeling so miserable that a lot of them started going back on at that point, or asking, should we go back on, and asking more questions about it. So
sure.
What kinds of hormone replacement therapies are out there for women to choose from?
If a woman still has her uterus, then it's very important to be on an estrogen, which is the main component that helps take care of the symptoms, such as hot flashes, night sweats, insomnia, which kind of goes along with that too.
Sure.
Maybe some mental fuzziness, depression. There are tons of side effects. If you looked at the list of menopausal symptoms, it's a long list.
Right.
But basically, if you have your uterus, then you should take an estrogen combination as well as progesterone. And the progesterone is there to basically prevent getting uterine cancer. If I gave you estrogen and told you to just take it day in and day out for a few years, you may very well develop uterine cancer. So if you have your uterus, those women that don't have a uterus don't need to take the progesterone component. But it comes in oral form, comes in transdermal form, which comes in the form of a patch, comes in transvaginal form in the form of a ring or creams or little tablets. It comes in actually implant form, and that is hard to get in the U.S., but so it's not around. It's comes in injection form. What other forms? Sprays, mists, gels, you name
Wow.
it, basically.
So what makes a decision on which one to use? I mean, how do you decide which one to use?
Very individual. I think you have to individualize for each patient on what their preferable mode is, basically, of how they want to take it. Also, there are some indication that at least orally, that medication has to be passed through the liver in order to be broken down into its main active component. So in women that may be on certain medication, that they can't absorb it through the gut as well, or that they have liver disease, alcoholism. There are some people that basically would be better off to have it in a transdermal form, which actually gives you a little bit more even distribution, more even absorption, and does not have to go past that liver bypass system.
That makes sense.
It also shows that the transdermal forms basically don't increase the risk of blood clots nearly as much as your oral form does, and it has no change on the lipid profile. Your cholesterol, your triglycerides, that type of thing. So in some women, say if they have a tendency maybe towards one portion of heart disease or not, then you may want to go with a transdermal form over the other. There are also just plain old vaginal estrogens that can be used just for urinary symptoms and issues, or for vaginal dryness. Sometimes intercourse becomes very, very uncomfortable after intercourse. I mean, after the change, and so those kind of medications can be used, and you don't have to take an oral or what we call a systemic medication then.
So it's really sort of an individual choice, and or depending on what the physician sees the history of that person is, or what they're taking for medication, or there's a lot of factors, it sounds like.
There's
that
a lot
makes
of factors.
A huge amount of factors involved in that. Well, as far as hormone replacement therapy is concerned, is there an age at which you would be beneficial to start them, like maybe before menopause? Do you wait until the symptoms show up? Is there any benefit to getting a head start?
It's probably not a benefit necessarily getting a head start on it, but what that WHI study did show is that women that started it right around menopause, in those first few years of going through their change, meaning having that last menstrual period, they did almost seem to get a cardiac protective effect. And especially if they were on it for a certain length of time, shorter length of time, and did not have any heart issues before they started. And they found that that actually was a little bit of a protection there. So we really urge women to start it at the time where they're close to menopause. Certainly less than 10 years from that last period is very beneficial, we're finding. Whereas if you wait until you've already had the heart problems or underlying issues, that may actually possibly provoke heart disease, strokes, blood clots, that type of thing, and is certainly not as beneficial.
Now, if a woman is going through menopause and really is not having a lot of symptoms like hot flashes and things like that, is it still beneficial for her to go on hormone replacement therapy, or is she better just, if it's not broke, don't fix it?
I'd say if it's not broke, don't fix it. And it mainly is because of the increased risk of breast cancer that I think we do. I think we do realize we find. But again, it depends on her situation. The benefits of being on estrogen replacement are it does help the bone density.
Okay.
We do know that, absolutely. It does decrease the risk of colon cancer. So possibly if you had a patient that had a high history or high risk of osteoporosis and or colon cancer, then you might want to consider hormone replacement for them. But again, we certainly urge it in that kind of younger age group or that early menopausal type situation rather than later.
I was going to ask you about osteoporosis because I know that there has been some issues with osteoporosis and people using hormone replacement therapy to help with prevention, right, of some of the real serious issues with osteoporosis. Is that right, then?
It is. It can decrease the risk of fractures, not only in the hip, but also of the vertebra. So it is a known treatment for bone health, basically.
Oh, that's
And,
great.
so
Now,
yeah.
is there a time limit when women should stop taking hormone replacement
Well,
therapy?
and that's a good question. We don't know that exactly, but I think, again, most people would say if you use the hormone replacement for symptoms at the lowest effective dose that will treat the symptoms for the shortest period of time, which is usually considered to be 5 years. So you're thinking of if menopause occurs at 52, you know, probably kind of through the early 50s into the mid 50s. I think most of us would say be off by 60, but that's not hard and fast either. There are some women that try it off, and it's important to wean off very slowly, because if you just suddenly stop it, you'll probably have the recurrence of your hot flashes all over again, which is no fun. So we encourage women to wean off very slowly, but I have several patients that have done that, and they are still kind of miserable, and so they opt to go back on it. But you know, we provide informed consent. We make sure that they know the risks versus the benefits, and it's kind of weighing those,
Sure.
and they make the decision whether to go on it or not, basically.
Now, recently there's been some articles that I've read that have to do about compounding or
Bioidentical, probably.
bioidentical. Yes. So could you talk a little bit about those?
Those are hormone compounds that are basically made from plant type products, and it's usually yam, soy, or plant extracts that have estrogenic effects, and they're basically what most people consider a natural estrogen or natural product that tries to mimic what the own body has. There is a lot of controversy about those kind of products because estrogen is estrogen, no matter how it's produced. Our estrogens, and I wouldn't say our estrogens, I do use the bioidentical, which are the same as compounded hormones, basically.
Okay.
And they're made by a compounding pharmacy from these products. And so they can be tweaked a little bit, the dosages, and they can be combined with other things and however they want to do it. And it's usually creams or sometimes capsules, gels, those types of things. The problem is the FDA has not studied those to see, well, is this compound equivalent to Premarin, over
Okay.
here? And so we don't know exactly what that is going to do to the body. I have several patients that do use them. I'm okay with that, and they do seem to do the job and do the take care of the symptoms. But yeah, it's just hard to find the equivalent. And like I said, if you're making estrogen is an estrogen, no matter how it's made. And some of the products that the pharmaceutical companies are producing are yam products, soy products, that type of thing, are based on plant.
So at this point, we don't really have the research on that either, so we wouldn't really be able to say one's more effective than another or something like that.
There are a couple studies that I came on to that I think will be maybe written up in 2012, so maybe we'll know that a little bit better. There are also, hormone replacement is not the only thing. In breast cancer patients, we generally do not like to prescribe hormone or estrogen. And they do, in those situations, recommend some types of the antidepressants that are around. Effexor is one that's been studied fairly well through the years. What are called the SSRI type of antidepressants, the Prozac, that type of medication will often help with hot flashes. And so sometimes women take those. The other products that are around that aren't estrogen or aren't hormone that women do try sometimes are soy products, flaxseed products.
St. John's wort, I've heard
St.
that
John's
one before.
wort would be one. Black cohosh is another one, and they really haven't found that those are any more effective than placebo typically. I have several patients that do try those, and they say, yeah, it seems to help. So,
Believing sometimes makes it true.
And exactly, the
That's
placebo effect is convincing sometimes.
If you're taking hormone replacement therapy, though, is that generally covered by insurance?
It is. Again, it depends on your policy, and they have level 1, level 2, the tiers now. So generally, they'll want to go to a generic brand, where all of the hormone products are not generic at this point. So you do pay a little chunk sometimes. The compounded products are not covered by insurance, though, and they can be fairly expensive too.
Yeah.
Would you say that overall the benefits of using hormone replacement therapy outweigh the risk at this point? I mean, if I was a woman who was just going into menopause and trying to make a decision, and I'm reading a lot about all the risks out there, would you say the benefits outweigh the risks?
I would have a little hard time telling you that.
Okay.
I think what happens is most women that go through menopause, probably 60 to 70% anyway, they do have some symptoms. And most often it's going to be the hot flashes, the night sweats, vaginal dryness, and those are kind of the top 3 that we deal with. If you wait a little while, those will usually get better and less frequent over a period of time. But there are probably 10 to 20% of women that have a really bad problem. They're up all night, they're sweating all night, they soak the bed, they can't sleep, and therefore the next day they can't function, and then they may get depressed or whatnot. And so in those women, I think it's certainly beneficial as far as quality of life goes. I think long term, you shouldn't probably be on them very long term. But what they're finding is certainly a lot more encouraging than back in 2002 when that first study came out. I think we're finding that those women, right now that are going through that, it's not nearly as bad as it seemed to be back then.
Okay, well, thank you so much. Thank you, Pat, for joining me, and thank you so much, Dr. Hutchins, for being here. This is a very important topic, and I think a lot of women have the same kind of questions that we've answered today. So,
Good.
we thank you for joining us today. This is Women's Health, and Women's Health is an initiative by 10 Health, the channel, and the Mayor's Commission on Women, and we've been talking today about hormone replacement therapy. If you have questions or comments that you would like to ask, please feel free to contact us, or if you have issues or something that you would like to have us use as a topic on women's health, please let us know. Again, thank you, and this has been Women's Health.